Right. Okay, guys. So now, now we'll come to the second session of osteoarthritis. So we will discuss today the diagnostics and the management, diagnostics and management of osteoarthritis. Give me a second to share my screen. First thing, guys, right? Right. Right. Look at this, guys. The first thing I want you all to do, right? Go to our note yesterday, guys. There is a small correction to be made there, right? It's a technicality, right? Let me explain what I mean, right? Go to this synovitis place, guys, where in the pathophysiology we talk about inflammation of the synovium that can go, the inflammation can spread to other locations, right? It's not very common, but possible. Bursitis, enthesitis, all of these can happen, right? But since the inflammation is not very severe, right? You all know in biomechanical arthritis, which is this osteoarthritis, we generally have a very mild inflammation. We have a mild inflammation, right? Now, what I want you all to know here is we yesterday talked about when this inflammation heals, it can heal with fibrosis. This is what we called periarticular fibrosis. Now, when periarticular fibrosis happens, guys, what happens? The type A and type B cells in our synovium, the synoviocytes, their functionality reduces. So we said, especially when the type B cell function reduces, we said synovial fluid can be reduced. But this, we cannot say it like this, guys. How we say it, first of all, I want you all to cut this off, right? Cut this off. How we say it is like this, guys. Due to periarticular fibrosis, what we say is, now what are the components of synovial fluid? We have hyaluronic acid, right, and lubricine, and then we have some proteases, collagenases, etc. But main two are this hyaluronic acid and lubricine. What we say is, guys, these two production can reduce a little bit. This hyaluronic acid and lubricine can reduce a little bit. Therefore, what does hyaluronic acid do, guys? It helps prevent friction, right? It helps prevent friction by keeping the viscosity high. Because of this, guys, we can say, right, the friction is going to increase here. The friction is going to increase here. Now, why don't we just say that synovial fluid reduces and therefore the friction increases? Why we don't say this is, guys? Because of this. In the diagnostics, there is something called joint fluid aspiration. We basically put a syringe like this, right? Through the needle, we pierce into the joint, into the synovial, into the joint space, and take out some joint fluid, right? Synovial fluid will be taken out. Now, look at this, guys. When there is inflammation, what did we say? There is joint effusion happening, right? A transudate can start leaking into this joint space, So although the hyaluronic acid and lubricine production is reduced, right? At the same time, what is happening, guys? A lot of inflammatory infiltrate, especially this transudative fluid, starts coming in due to this inflammation. So overall, when you aspirate from the joint, what do we see, guys? We say synovial fluid volume is high. Why? Although there's reduced hyaluronic acid and lubricine, at the end of the day, there is a lot of inflammatory material coming in, transudative material coming in. Therefore, that is why there is joint effusion. There's fluid filling inside this joint. Therefore, guys, when we aspirate it, the joint fluid or the synovial fluid, right, we say that the volume is higher. Okay. Now, if there was a separate name for this, if we thought synovial fluid was completely separate from joint fluid, then yes, you can say synovial fluid is less, but joint fluid is overall high, right? But there is no separation like that. Whatever we aspirate into this needle, we still call it synovial fluid. So the overall synovial fluid volume will increase, due to the inflammation. We will see this in the diagnostics today as well. But I just want you all to cut off this place where we wrote that synovial fluid reduces. We cannot say that. Although the hyaluronic acid and lubricin reduces, we cannot directly say synovial fluid reduces, because the synovial fluid contains all these inflammatory infiltrates, transudates, everything, right? So therefore, synovial fluid we say increases. Okay, right. Now, after covering that, guys, we'll dive into the diagnostics. Diagnostics, right? Diagnostics. Okay, diagnostics. In the diagnostics, guys, one of the first things, first of all, let's break this down into generalized clinical features. Generalized clinical features, right? Generalized clinical features. What are these generalized clinical features, guys? First one is joint pain. First one is joint pain. Joint pain. This joint pain, guys, what do we call it commonly? Arthralgia. Arthralgia, right? Especially on movement. Especially on movement. You all can put it in brackets, right? On movement and weight bearing. And weight bearing. Right? On movement and weight bearing. So what is happening here, guys? What I want to highlight here, joint pain early in the disease. In early disease, guys, we can have what we discussed this yesterday, intermittent or episodic pain, right? Intermittent pain, right? Intermittent pain. We have discussed why this happens in the pathophysiology, right? Second thing, guys, in advanced disease, what do we see? We see persistent or continuous, right? Persistent, and you can put plus or minus nocturnal pain. Sometimes, guys, these patients, even when they're sleeping at night, they're not moving, right? Still, there is pain, right? At night, okay? Nocturnal pain, right? Then, the next thing I want you all to know, guys, reduced, right? You can say functional limitation. Functional limitation. Now, these are all, guys, right? You all can put the major topic under these generalized clinical features. You all can put it as a subtopic. Now, these are all symptoms. These are what are experienced by the patient. Functional limitation, right? Functional limitation. They can feel that affected joint. They cannot move it properly, right? There can be stiffness. There can be pain. All of that, right? I want you all to understand here, guys, the functional limitation can be brought about by the pain itself, not just by the osteoarthritis. Now, with the osteoarthritis pathophysiology, due to inflammation and all of these, there can be increased friction and therefore reduced motion, right? At the same time, the pain itself can discourage the patient from moving that particular joint, right? That is what I want you all to understand here. The next thing, guys, the next one I want you all to understand, right? Look at this. Number 3, right? Morning joint stiffness. You all can say early morning joint stiffness. Early morning joint stiffness. What is happening here, guys? Look at this. Throughout the night, guys, what is happening? Is the patient moving well throughout the night when he's sleeping? No, unless they're sleepwalking, right? Throughout the night, joint movements will be reduced. Joint movements will be reduced. Therefore, what do you all think happens to the lymphatic function, right? In the synovium. You all know the synovium is it has a good vascular supply. It has, give me a second, guys, right? It has a good vascular supply, it has a good neuronal supply, and it also has a lymphatic supply. So what happens is when joint movement is reduced, lymphatic drainage is reduced, guys, right? Lymphatic drainage is reduced, okay? When lymphatic drainage reduces, guys, our synovial fluid flow rate reduces. Because what is happening is, guys, usually type B synoviocytes are going to be producing new synovial fluid, basically our hyaluronic acid, our lubricin, and some other molecules, right? And at the same time, some synovial fluid is taken back up by the lymphatics and put into circulation, right? There is a synovial fluid recycling happening, guys, right? Our body maintains this in order to remove any unwanted materials, right? The synovial fluid needs to be recycled, right? Okay. Now, so there is sort of like a stasis, guys. You all can say sort of as not exactly a stasis. There is no complete obstruction of the lymphatic system, but there is a sort of a stasis, right? A sort of a stasis-like effect of the synovial fluid, right? Right. There is one thing that happens. The second thing I want you all to know is, guys, right? Throughout the night, what happens? The inflammation can still continue. Inflammation continues, right? Inflammation continues. When the inflammation continues, guys, right? What is going to happen? There is a lot of transudative fluid coming into the joint space, inflammatory infiltration into the joint space, right? Inflammatory infiltration to the joint space increases, right? Inflammatory infiltration. Now, these inflammatory infiltrates also what happens? They also cannot be taken away by lymphatics. Why? There is a relative stasis. So these inflammatory infiltrates, whatever come, it will stay, right? Some of it will manage to escape, but the major part of it will stay. Now, look at this, guys. As the patient wakes up, when the patient wakes up, what is his joint going to have, guys? There is going to be increased inflammatory infiltrate, right? Plus reduced hyaluronic acid, right? Plus, what is reduced lubricine? Reduced lubricine can be there. So all of these, now you all know inflammatory infiltrate also, guys. Inflammation, whenever inflammation happens, whenever there is inflammatory infiltrate coming in, right? The viscosity of that fluid can increase a little. So all of these together, guys, they can cause stiffness, right? Why? Right? Because of the increased viscosity. However, this is what I want you all to highlight here. The early morning joint stiffness in osteoarthritis lasts a maximum of 20 to 30 minutes, not more than 30 minutes. Not more than 30 minutes. When we tell the patient to do some movements, right? So the patient wakes up, his joints feel stiff. We tell the patient, okay, do some minor movements of the joint, some slow movements of the joint. What happens with those movements, guys, right? You can write down a little bit of movement, do a little bit of movement, right? Or a little bit of exercise, right? And what will happen? All this material, the lymphatic function will be regained. Lymphatic, right? Function regained, right? Lymphatic function regained. Therefore, what happens, right? Therefore, now all these inflammatory infiltrates, right, can be carried away at the same time, right? The type B synoviocyte will increase their function a little bit to produce new synovial fluid, produce more hyaluronic acid, right? So because of this, after a while, after about a maximum of 30 minutes, guys, right, the lymphatic function is restored and the synovial flow rate is back to normal, right? And the stiffness will reduce. Okay, stiffness reduce. This is because of this phenomenon, guys. It is called also, especially in some old books, we call this joint gelling. Okay, joint gelling. Okay, right. So these are the major symptoms I want you all to understand. The next is, guys, some signs. We'll talk about some signs, right? Some signs. What are these signs here? The first ones, these are what you as the doctor, what you can see, right? Reduced range of motion, right? This can be whatever the joint that is affected, hand, hip, knee, anything, right? Second one is, guys, joint tenderness on palpation. Joint tenderness, right? This is basically due to the inflammation, right? The pain fibers are going to be stimulated. We'll talk about some of these pathways, right? Because of the inflammation, basically, right? Next one is, guys, crepitus at the joint, right? This is why yesterday we saw in the knee osteoarthritis video as well, right? due to the irregular bony surfaces, irregular cartilage in the surfaces, fissuring, fibrillation, and the osteophytes. Because of all of these guys, right? Usually the joint movement is very smooth like this. Now what is happening? The joints, as they move, there is increased friction, and because of this, you can feel some crepitations. You can feel some crepitations, right? Hibernation, joint space narrowing, right? Fissuring, fibrillation, all of these can cause these crepitations, right? The next one is osteophytes and bone swelling. Osteophytes and bone swellings, right? These ones, guys, now these signs means what you can see in the patient. These osteophytes and bone swellings, guys, in some large joints, we usually can't see them. For example, knee and hip, from the outside, we usually cannot see them. We can see them maybe when we do the x-ray. But especially in the hands, guys, these osteophytes can be seen. These bony swellings can be seen, right? Sometimes there are some, we'll talk about hand osteoarthritis, nodal osteoarthritis. We can see them as nodes, right? We'll talk about all of those, okay? Right. Then the next one, guys, signs of joint effusion. Signs of joint effusion, guys, basically, right now, we're talking about swelling at the joint, right? Pain and stiffness at the joint, redness and warmth, all of these can be there, right? Then the next one is, guys, adjacent muscle wasting. Adjacent muscle wasting. Now, why this muscle wasting exactly happens, we don't know, guys. There are several hypotheses, right? Some papers, they suggest, right, the inflammation itself, right? Although it is a mild inflammation, some inflammatory cytokines and some inflammatory material itself can go and destroy adjacent skeletal muscle fibers, right? This is one theory. There are some other theories that suggest, right, that the pain itself, when there is pain, the patient will be discouraged from moving those painful joints, right? Therefore, over the long term, guys, what happens? The patient doesn't move those joints, so those muscles undergo atrophy, right? Because those muscles are not utilized, right? So muscles undergo atrophy with time. That is another theory. Another third theory suggested this, guys, there are some genetic mechanisms that they suggest, right? They say due to the inflammation and various pathological changes going on, right, there can be generalized genetic alterations in the muscle fibers, right? Okay, maybe some protein synthesis related things, right? We don't know yet. We don't know why exactly this happened, but definitely it has been seen, right, and observed in patients with osteoarthritis, adjacent muscle wasting. Okay, right. Okay, now once that is done, we will go to the diagnostic side specifically. So this, what we talked about now, is generalized manifestations, generalized clinical features. Now we will talk about, towards the end of the class, guys, we will talk about some specific manifestations, like specifically for hand osteoarthritis, specifically for knee osteoarthritis, things like that, right? We'll discuss. Now, these are some general manifestations that all forms of osteoarthritis can have, right? These are the ones that we have talked about now. Now we'll go for some lab findings. Again, we'll look at some generalized lab findings, right? You all can put the topic, lab diagnostics. Lab diagnostics, right? The first line, guys, the first line for lab diagnostics is X-ray. We tell the patient, go get an X-ray, right? Whatever, if the patient comes with a joint pain, right, they complain symptoms on activity, symptoms on rest, it doesn't matter, right? First thing, one of the first lines is X-ray, right? Radiographic image, right? Now, what I want you all to know here, guys, yesterday in the pathophysiology, what are the pathophysiological changes, the pathological changes that the joint undergoes that we discussed? We talked about cartilage destruction, cartilage thinning, Then we have loss of joint space, right? Loss of joint space is important. Apart from that, guys, there can be fibrillations and fissuring of the cartilage, right? Apart from this, the bony changes, subchondral sclerosis, subchondral cysts, osteophyte formations, right? All of these we have discussed yesterday. These changes, guys, right, especially the bony ones, right, can be observed in X-ray. What I want you all to understand is X-ray, especially in early osteoarthritis, guys, X-ray may be insensitive, to the pathologic changes. What does that tell us? Although the patient has these, all early osteoarthritis, guys, we said, so if we take osteophytes, they will be very small and lesser in number. Same with cysts, right? The sclerosis won't be severe. Therefore, these changes cannot be properly appreciated on an X-ray, especially in early. In moderate to severe, guys, when these changes are much more exaggerated, it can be better observed, right? Okay, let's look at some of these generalized things, guys, that we want to observe on X-ray. Go to your skeletal notes, right? Right, I have put some images here. Let's first go to this. Now, B here is the normal one. B, this is a knee joint. This is a knee joint. Our B is the normal, right? This is a normal X-ray of a normal knee joint. Okay. What I want you all to realize first, right? The joint space. Firstly, guys, when we are assessing joint space is usually constant throughout the joint. There is a constant joint space, right? That is how it is in our normal joints, right? As opposed to that, look at this A diagram. Here, somewhere here, the joint space is very large. Somewhere when we come somewhere here, look at the joint space, very small, right? So there are joint space alterations, right? Joint space narrowing, we call this joint space narrowing. Give me a second, guys. I think my screen is a bit stuck. Right? Okay. Right? Yeah. Look at that. That is joint space narrowing, right? Joint space narrowing. This, look at this C1, guys. Same. Look at this varying joint space lengths, right? Varying joint space lengths, right? Okay. These are varying joint space lengths. These signify, right? What? Joint space narrowing. Okay. Then this D patient, D1, right? Look at this D. Here, guys, what I want you all to know, if I say, okay, I will say this is the medial aspect of the knee joint, medial aspect of that joint. This is the lateral aspect of that joint, right? In the medial aspect, what do we have? Complete loss of joint space. Look at that. The joint space is completely gone. On the lateral aspect, it's a little bit better, right? It's a little bit better, but still there is joint space narrowing, and on the medial side, complete narrowing. Okay, this is one of the first things I want you all to look for when you're looking at an X-ray, joint X-ray, right? The joint space. Okay, right. Let's go to this second one. Okay, give me a second. Right. Let's go to this second one. In the second one, right, in this second image, what I want you all to look for. Look, first tell me, which one do you think is the normal one? This B here is normal. The B diagram is normal. Right? Look at the A diagram. The first thing I want you all to notice, loss of joint space, right? Loss of joint space. And there are irregularities, right? Here it's almost none. It appears like a bone-on-bone appearance. Apart from that, guys, look at this region, right? This region. Okay. This is what, guys? This is subchondral sclerosis. Subchondral sclerosis. Subchondral sclerosis. Right? Subchondral sclerosis. Okay. subchondral sclerosis. Right. Then come here, right? Look at these four. Look at these four. Again, what is the normal one, guys? This B1. Look at the marginal joint shape, guys. It looks like this, right? The margin looks like that. Look at this A diagram. You can see a small lipping sort of that mark. That is an early stage osteophyte, guys. It is a very tiny osteophyte, right? It's a very tiny osteophyte. As opposed to that, look at this C diagram, right? There is one there, right? Somewhere here, there is another one, right? These are a little bit larger osteophytes. Look at the D1, right? Very large osteophyte formations, right? Osteophyte formations. Okay, right. Now, let's go a little bit more down. Look at this one. The A diagram, this is a hip, guys. This is a hip. The A diagram is a hip, right? Here, what do I want you all to notice? First thing, again, right? Loss of joint space. The joint space is irregular. Somewhere here, there is a little bit more. This area is almost none, right? Again, here have a little bit, right? So this is loss of joint space, right? And here a little bit more, right? What I want you all to understand here is, guys, look at these structures, right? What are these? These are subchondral cysts, right? Subchondral cysts, right? Now, some of them you can see, right? Some of them has the communication still open with the joint space, right? Some of them are completely, the cortical bone has healed, okay? Subchondral cyst, guys, what is it filled with? What is the liquid inside? Synovial fluid, okay? It can obviously have some inflammatory infiltrates and all of that, right? Due to the nature of the osteoarthritis, but it is basically synovial fluid, right? Okay, let's look at this B diagram, guys. This is a knee. This is a knee. Look at this, several things I want you all to appreciate, right? Here, guys, what can we see? Look at these. These are marginal osteophytes. And here, guys, in this white and black arrow, right? It's not very clear, but somewhere here you can see, right? A much more darker regions. If I erase those lines, you all can probably see it better, right? A little bit darker, right? It's not very clear, but a little bit darker. These are what? These are cysts, right? And here we can also appreciate again some sclerosing parts, some sclerosing regions, okay? Some sclerosis. Right. Now, let's come back, guys. Look at this. So that is about X-ray. Some general findings in X-ray. We will look at some specific ones as we go along for other types of osteoarthritis. The second one I want you all to know, guys, MRI, magnetic resonance imaging, right? This one, first thing I want you all to know, this is not routine. Guys. We don't tell every patient to get an MRI, but it is done, or it is prescribed, right? We ask the patient to go and get one of these, an MRI, especially one special case, right? Especially, guys, if it is spine osteoarthritis, and nerve root compression is suspected. Right? Nerve root compression is suspected. Okay, nerve root compression is suspected. Apart from this, guys, it can also be indicated in some severe sport injuries like these meniscal tears. This happens, guys. You all know these rugby players, right? They are very well known for these knee meniscal tears, right? And sometimes the cruciate ligament tears as well. Okay, so in those kind of situations, yes, you can suggest an MRI again to assess the damage, right? In osteoarthritis, mostly to spine osteoarthritis, if nerve root compression is suspected, if the patient complains there is some radiating pain, if they complain there is some tingling sensation, right? That is a suspicion for nerve root compressions. Okay, right. The next thing is, guys, Third one, diagnostic arthroscopy. Right? What is this diagnostic arthroscopy? Because I've put a picture right here, this picture, right? Basically, guys, what are we doing? We are inserting a small fiber optic camera all the way into the joint space, right? We have to make a small incision. This is a minimally invasive procedure. You can send this fiber optic camera all the way into the joint space and look at everything, right? So it's invasive, therefore not commonly performed, guys. But what do you all think about the sensitivity of this for early osteoarthritic changes as opposed to x-rays? It's very, very good, guys. X-rays, you all know, it's not very sensitive to early changes of osteoarthritis. Okay, this one much more sensitive to early changes of osteoarthritis, right? Okay, right. Then we will come to the next one. Okay, look at this. The next one is biochemistry. Basically, guys, we are talking about the blood, right? What are we going to look for in the blood, right? This one, guys, usually, okay, look at this. First thing, we look for some inflammatory markers, right? ESR, erythrocyte sedimentation rate, CRP, C-reactive protein. Most of the time, guys, right, you all know, inflammation is mild in osteoarthritis, always mild, right? It is mild inflammation. What do you think about the ESR and CRP? Most of the time, normal. Right? There is a newer one, guys, called highly sensitive or high sensitivity, right? CRP, high sensitivity CRP. This high sensitivity CRP, guys, even in very mild inflammations, this can show an elevation, right? Therefore, what do we see? This one can be, can be positive. Not always, but can be positive. High sensitivity CRP, right? Right. Apart from this, guys, we can check for rheumatoid factor. Don't worry, this rheumatoid factor you all will completely learn in the inflammatory arthritis, in rheumatoid arthritis, right? Rheumatoid factor will be negative, and same with anti-nuclear antibody is also going to be negative, right? Don't worry, these you all will learn in the inflammatory arthritis chapters that are coming up, right? What these are, why they are getting positive, all of these you all will talk about, okay? Right. The next one, guys. Now, listen carefully, right? This point, listen carefully, right? Number 5, right? Synovial fluid aspiration, right? Synovial fluid aspiration. This one is also called, guys, atherocentesis, right? Atherocentesis. Now, what I want you all to know, this one is usually indicated if there are manifestations of joint effusions, maybe like a swelling, right? Some pain and stiffness, these kind of manifestations, right? If there are, we will suggest a synovial fluid aspiration. Now, what is the important thing I want you all to understand here, guys? If there is joint fluid effusion, right? If there is joint effusion, what does that mean? That means there is some sort of inflammation. But this inflammation is what? Always mild. This inflammation is always mild, right? Never severe, right? Therefore, now tell me this. Let's leave osteoarthritis aside for a while. Tell me this. If you look at a normal person's synovial fluid, what do you think about the viscosity in a normal person? High or low? In a normal person, the viscosity is high, guys. Viscosity is high. This is provided by the hyaluronic acid mainly, right? The hyaluronic acid helps to maintain this high viscosity, right? Now, what happens, guys, in during inflammation, we said hyaluronic acid production by the synoviocytes is going to reduce a little bit. So technically, what do you think happens? Technically, what we would assume is that the viscosity would also reduce, but it is not so. Why is that? Look at this, guys. It is true. It is true that a little bit of hyaluronic acid, lubricine, all this, whatever is produced by the type B synoviocytes, it can reduce. That is true, right? However, when you aspirate the entire joint fluid, when there is inflammation and everything going on, what do we have? Although hyaluronic acid and lubricin can be reduced a little, right? We also have inflammatory infiltrate at the joint, right? Okay, we have all these inflammatory infiltrate. You all know inflammatory infiltrate, guys, whenever they are there, right? They increase the, not just the joints, right? Whichever compartment, right? If there is inflammation, there is going to be an increased thickness of the fluid in that area, viscosity we say, right? So although, right, the type B synoviocyte hyaluronic acid production is reduced, at the same time, what is there? There is inflammatory infiltrate. Therefore, right, the viscosity, guys, does not reduce, right, with synovial fluid aspiration, right? True or false question, right? True or false question. Synovial fluid aspiration in osteoarthritis shows reduced viscosity or shows low viscosity. This is false, guys. In osteoarthritis, right, it is true that a little bit of hyaluronic acid and lubricin production will reduce, but added to that, at the same time, there is inflammatory infiltrate. So that viscosity remains high. Viscosity doesn't drop just because there is a mild drop in the hyaluronic acid, right? Okay. So in osteoarthritis, viscosity is again high. Viscosity is again high. This is an important question, right? I hope you all understand. Right? Next, guys. Next, we'll look at some comparison in this synovial fluid aspiration. We'll look at some comparison. We'll look at the measures, right? Measure, right? And we'll look at a normal joint, and an osteoarthritic joint, right? Right. The measures, guys. Again, we'll start off with viscosity. Viscosity, right? We will talk about volume. Volume, guys, mainly we want to focus on the knee joint. Other joint, we don't need to know the volume of synovial fluid. Okay, the volume, right, in milliliters. Okay, and then we'll talk about the clarity, right? We'll talk about the color, the clarity, the color, right? And we'll talk about the amount of WBCs present. WBCs present per microliter. Okay, WBCs per microliter. And then, guys, we'll also mention if you culture these, what you will see, right? Now, in normal, viscosity high. In osteoarthritic joint, also viscosity is high. This is what we talked about, right? Volume, guys, volume, you all know in the knee joint, yesterday also we mentioned, usually it's about 1 to 4 milliliters, right? So in a normal joint, we usually say it is never going to exceed 3.5 ml, right? In a normal joint. In an osteoarthritic joint, what do you think? Volume increased or reduced? Synovial aspirate, right? Synovial fluid volume, guys, we say often greater than 3.5 ml, right? Often increase. This is what we talked, is what we corrected at the start of the class. Okay, right. Then clarity, guys, clarity. How clear does this look, right? Normal synovial fluid is transparent. It is transparent. Osteoarthritic joint, what do you think? Is the inflammation serious? No, this is a mild inflammation. Here is also transparent. It is transparent. Okay. Color, guys, usually this is colorless. In the normal one, it can be colorless, or sometimes it can be lightly straw colored, we say. Straw colored, right? Osteoarthritic joint, it can be straw colored. right? Or sometimes, guys, if the inflammation is a little bit more serious, right, it can be yellowish in appearance. Okay, yellowish in appearance, right? Okay, WBCs per microliter. WBCs, guys, usually in the normal sample, we say it's less than 25. What do you think about osteoarthritis? Right? Osteoarthritic joint also less than 25. There is no significant inflammation. That's what we said. It's mild inflammation. It's usually normal levels. Normal levels, right? Culture, guys. If you culture this, obviously this will be negative. Did we talk about any pathogens coming in? No. That is infective arthritis, right? We are not going to talk about those, or septic arthritis, right? Cultures are going to be negative. Okay? Cultures are going to be negative. Right? Is this clear? Right? So these are some general diagnostics, guys. General diagnostics. Now we will go to some specific clinical subsets, right? Look at this. Put the topic. Right? Clinical subsets of osteoarthritis, right? Okay, let's have a look what we are talking about here, right? First one is, guys, nodal osteoarthritis, right? Let's go through your skeletal note a little, right? Nodal osteoarthritis, guys, here, right? Look at this. Most commonly, it is in the hand, but it can also occur as generalized osteoarthritis, guys. It can affect any joint, right? There can be nodal osteoarthritis of the knee, nodal osteoarthritis of the hip, right? It can affect any joint, but most common in the hand, right? Female, guys, there's a very high predisposition. Females much greater risk than males. Okay. Apart from that, the peak is in the middle age. There is a strong genetic predisposition and sometimes maybe asymptomatic, right? Now we'll look at the pathologic changes, guys. Look at this picture. First thing I want you all to appreciate is these nodes, guys. These nodes, look at these areas, right? Look at these areas, right? Maybe somewhere here also, right? These nodes, right? These are characteristic, guys, for this nodal osteoarthritis. These are basically from these osteophytic formations, right? But they are a little bit exaggerated because our fingers are very thin skin structures, right? As opposed to somewhere like our hip. You all know our hips are usually surrounded by musculature and all, so we cannot see, right? But these ones, right, they become very prominent and visible, right? Let's take a look, guys. Let's draw a small hand, right? So y'all can draw with me something like this, right? Okay, these are some carpal bones, right? Okay. This is our thumb, right? Then we have main fingers, right? And our little finger, right? Something like this, right? So this is my left hand, right? Now, look at this. What I want you all to know, guys, right? Here, in this nodal osteoarthritis, there are some characteristic findings. Look at this. The first thing, guys, right? These nodes, they can affect some of these joints. Look at this. Sometimes the nodes can be here, guys. Sometimes here. Now, if I call this A, right, and this is B. A is what, guys? A is the distal interphalangeal joint. Distal interphalangeal joint. B is what? Proximal interphalangeal joint. Proximal interphalangeal joint, right? Here you have these are what, guys? These are our metacarpals and our carpals. Guys, I have made a mistake here. No? I forgot to draw one more bone here. Right? Something like that. Right? Yeah. Okay. So here, these bones, these are our metacarpals. These are the small ones, are our carpals or wrist bones, right? Carpals, right? Now, so first thing I want you all to know, guys, in this nodal osteoarthritis, right? These nodes are given special names. The nodes occurring at the distal interphalangeal joint, we call them Heberden nodes. Heberden nodes. The ones occurring at the proximal interphalangeal joint, guys, we call them Borchardt, right? Borchardt, right? Now, how to remember this? How to remember this? Just this is the easiest way, guys, right? This is the easiest way that rather I use. You all also can probably use this, right? Right. If you point your fingers, right? If you point your fingers using your hand, point your first finger out. Point your first finger out, right? It's going to look like this, right? What I want you all to do, point your first finger out like that, and write the alphabet, right? A, B, C, D, E, F, G, H, right? H is there, guys. H is here, right? Okay, H is there, right? And B is here, right? So Heberden, Borchardt, right? Heberden and Borchardt. Distal one is Heberden, proximal one is Borchardt. Now this one you need to know, guys, right? Because for true or false, right? You get questions like true or false questions, right? You find Heberden nodes at the proximal interphalangeal joint. You should know that it's false because Heberden is found at the distal interphalangeal joint. Okay, so you should know these for these true or false questions, right? The second thing I want you all to know about nodal osteoarthritis, guys, characteristically, distal interphalangeal joint involvement is much greater than proximal interphalangeal joint involvement. Okay, that means what? If you look at the nodes, Heberden nodes are more commonly seen as opposed to Borchardt nodes. This is another true or false question, right? Heberden nodes are more commonly seen, right? Okay, that is true, right? It's more common, right? Then, now look at this. The next pathologic change I want you all to understand. There is, guys, at this joint, there can be the first, this is called the first carpometacarpal joint. First carpometacarpal joint. At the first carpometacarpal joint, guys, there is significant osteosclerosis. Significant osteosclerosis, right? Okay, bone thickening, guys. There is actually sort of like an overgrowth of bone there, right? And there can be a lot of destruction there as well, right? Now, why it's specifically there, right? We really don't know why exactly, but yesterday at the start of the class, we talked about in an evolutionary perspective, right? Since humans evolved this pincer grasp, a position of thumbs, right? All these abilities to do with the thumb, right? That was not initially meant for those functions, right? But we evolved with those, right? So maybe that's the reason. What is end of the day? Whatever the mechanism, there is sclerosis here that causes bone growth in this direction. At the same time, guys, what is happening? This distal end of the first metacarpal bone, the distal end of the first metacarpal bone starts moving towards the palm, right? Towards this palm aspect, right? Whereas this proximal end with the sclerosis moves away a little bit. There is growth, there is new bone growth, right? And this distal end is pushed closer to the palm, right? So what is this, guys? Whenever the thumb is being brought close to the palm, what do we call it? Adduction, right? So there is first metacarpal adduction, right? First metacarpal adduction. Okay, first metacarpal adduction, right? So the thumb will be appearing something like that, guys. This the two phalanx of the thumb will be outside, but right, the patient cannot keep their hand like this. In their natural state, their hand is something like this. Okay, something like this in their natural state. For us, it's like this, no? Right? Okay. Now, let's look at these changes, right, in the X-rays, right? Take your note, guys. Look at this. The first one, right? The first diagram, guys, I want you all to appreciate, right? We can see the Heberden and the Bochart nodes. It's not very clear, guys, but if you look closely, right, that is a Heberden node, right? Then here in green, I will put a Bochart, right? That's a Bochart. Here, maybe somewhere here, guys, there seems to be another Bochart, right? Another Bochart node there, right? I also want you all to appreciate, guys, joint space narrowing, right? Joint space narrowing at these areas, right? Especially in the second diagram, you can see this properly. Look at this. The joint spaces vary, guys. In these areas, here is one joint space, and then as we go, joint space reduces, right? See, right? So this is joint space narrowing, right? I want you to appreciate that as well, right? The next thing, guys, look at this. This is this first carpo-metacarpal joint. You all can see there's significant sclerosis. Significant sclerosis, and you can see the bone is a little bit moved in this direction, right? At the same time, what will happen? The distal end of this first metacarpal will be adducted, right? Adducted. All right. Look at this, guys. This second diagram gives a nice picture of the full hand, right? With this first carpo-metacarpal joint sclerosis, right? Look at this, guys. In the X-ray, right? There is severe sclerosis here, so you can see this bone, guys. Look at this. The first metacarpal bone is lined like this, right? From the phalanx, they are going outward. They can move, right? No problem. But this bone has been dragged. It has been adducted towards the palm, right? Especially from the distal end of the first metacarpal bone, right? Now, look at the hand, guys. Look at the hand, right? In the hand, firstly, we can see some nodes and some deformity here as well, guys. Look at this. In the X-ray also, we can see some deformity there. Huh? Okay, deformity also can be seen. But apart from that, look at this thumb, right? Can you see how the thumb is? Can you see how the thumb is, right? This, guys, this I want you all to appreciate. If you draw, you can draw a nice square shape in the dorsum of the hand or the palm aspect of the hand. We call this, guys, squaring of the wrist. Squaring of the wrist, right? Now this happens why? Because of this adduction of the first metacarpal joint. So now this is how they are in their relaxed state. Huh? If you just tell them to keep their hand on a surface, this is how it will be there. For us, it's not like that, guys. We can nicely abduct. Our thumb is usually abducted, right? Okay. Right. Okay. So those are some things I want you all to appreciate there. Next one, guys. I want you all to put this as a note, right? Say note, right? Note. There is, guys, something called erosive osteoarthritis. Erosive osteoarthritis. This is a subset of primary osteoarthritis, right? Erosive osteoarthritis is a subset of primary osteoarthritis. It's a subset of primary osteoarthritis of the hand, right? This is used to, guys, describe rare cases, right? Rare cases of hand osteoarthritis, with, right? You all can write this. First one, prolonged symptoms. Prolonged symptoms, sometimes for years and years, guys, right? You have pain, chronic pain, stiffness, all of these are there, right? Prolonged stiffness. Next one, guys, right? Severe disability. Severe disability, and you can put the third one, poor prognosis, right? Poor prognosis, right? Now, what are the characteristic features of this? Look at this. Characteristic features of erosive osteoarthritis. Guys, don't features. Don't mix this up with erosive arthritis. Okay, erosive arthritis is different from erosive osteoarthritis. Okay, right. Characteristic features, guys. The first one, proximal interphalangeal joints more affected than distal interphalangeal joint. Right now, this was the opposite in nodal, right? Okay. Next one. There is, guys, subchondral erosion of bone. We will see this in the X-ray, right? Subchondral erosion of bone. Third one, there is gull wing deformity, what we call a gull wing. Don't worry, we'll look at this in the X-ray, right? Gull wing deformity, right? And the next one is, guys, osseous fusion. Osseous fusions. What do we mean by this? In the joint, guys, the two bones start fusing, right? We call this what? What is the special name when bones are fusing? We call this ankylosis. Ankylosis can be that, right? Let's have a look at these X-rays. Look here, guys. The first one, right? The first one, what I want you all to appreciate, right? We can see, guys, look at these joint linings, right? These joint linings, let me take a, yeah. These joint linings, guys, look very abnormal. They are not straight lines, right? They are not straight lines, right? Okay, very abnormal, right? And there is reduced joint space, right? Reduced joint space. Okay. The next one, guys. The next thing I want you all to appreciate is here. Look at this. Severe joint erosion, right? Severe bone erosion. This is bone erosion, guys. Bone erosion, right? Erosive changes to the bone. This is seen here as well, right? Erosive changes, right? The next thing, very interesting, that I want you all to appreciate. Look at this, guys. Gull wings, right? This is what we call gull wings, like the wings of a seagull, right? Like the wings of a seagull. This is gull wing. This is severe deformity, guys, when this happens, right? Gull wing deformity, right? Gull wing deformity. And then look at this C1, guys. Here there is a nice presentation. Look at this area. Can you see a joint line here? No, we cannot see the joint line. What is this? The bones have fused, right? There is bone fusion, we said, right? Osseous fusions, right? So the bones have fused there, right? So this one's, guys, these result in severe deformities of the hand, right? And severe loss of function of the fingers, okay? Right? Okay. Let's go to the next one. Right? Second one is, guys. So that's what I want you all to know about hand. Huh? Now we go for knee osteoarthritis. Knee osteoarthritis. Okay. Knee osteoarthritis, guys, again, it can occur as isolated knee osteoarthritis, right? Or as a part of generalized nodal osteoarthritis, right? Either of the two, right? Usually, again, females greater than males, right? And what I want you all to know here, obese individuals, obese more than normal, right? Obese individuals more than normal BMR individuals, right? Here, guys, the pain, right? The pain. Usually, this is localized to the anterior or medial aspects of the knee, right? Anterior or medial aspects of the knee, right? There is, guys, reduced function, obvious, right? What do you do with the knee, right? You're walking, daily activities, rising from a chair, standing from a chair, right? Even when they go to the washroom, guys, it's difficult for them to stand up from the seated position in the commode, right? Uh, Simple activities like getting out of a car, right? Wearing your shoes, tying your shoelaces, wearing socks. So there can be, depending on the severity, guys, there can be a significant reduction in quality of life, right? In this knee osteoarthritis patients, right? Okay. Then, guys, examination, examination, examination. What are we going to see in the examination? The first thing I want you all to know is, guys, write this down. Antalgic gait, right? Antalgic gait. What is this antalgic gait, guys? It is basically limping, right? Antalgic gait, right? Okay, look at this, right? Let's have a look at this, guys. What is this? What is this antalgic gait story, right? Look at this. Antalgic gait is, guys, right? Basically limping, right? So let's say I am an osteoarthritic patient and I have osteoarthritis of my left knee, right? So what am I going to do? Whenever I keep my left knee on the floor, guys, when I keep my left leg on the floor, rather, right, my left knee is going to hurt, right? My left knee is going to hurt. Therefore, what do? I tend to give more weight to my right knee, to my right leg. I give more weight, right? This is what usually happens. Now, usually, you all know, guys, whenever we are walking, right? Whenever we are walking, there is at any given time, one leg will be on the floor, right? And the other leg can be in the swing phase. The other leg, we call it in the swing phase, and the leg that is on the floor, right? We call this the single stance phase, right? Now, what is happening is, right, when the left knee is hurting due to osteoarthritic changes, right? When the left knee hurts due to osteoarthritic changes, what do I tend to do? I tend to reduce the single stance phase on my left leg, and I tend to increase the swing phase duration on my left leg. What does that mean? I'm going to be walking like this, guys. More time on my right leg, right? Less time on my left leg on the floor, right? This is basically a limp, right? What we call koragahana, right? So it's going to be something like that. That is what we call the antalgic gait, right? Antalgic gait. Now, what is the important clinical correlate I want you all to understand from this? In the treatment part, guys, we will come to the treatment later. In the treatment, we are going to see, right? We are going to suggest the patient to use a walking stick, right? Especially for these knee osteoarthritis cases and sometimes for the hip as well. We can suggest the patient to use a walking stick. Now, I will use this meter ruler, right, as a substitute for a walking stick, right? If we are telling the patient to use this walking stick, right, to support their day-to-day activities, to support walking basically, what hand do we tell them to carry the walking stick in? Which hand? Right? Think about it a little, right? What we say is, guys, always carry the walking stick in the contralateral hand to the affected limb. So if I'm having a left knee osteoarthritis, I tell the patient, take the walking stick in your right hand. If the patient is having a right knee osteoarthritis, I tell them, take the walking stick in the left hand. Why is that? Just think naturally, guys. Now, what am I doing? Osteoarthritis, you all know, this is a chronic disease. So over sometimes months, over years, what will I do? Because my left knee is paining, I'm giving more weight to my right side, right? I'm giving more weight to my right leg and my right knee. Now, you all know, during single leg stance, 3 to 6 times of your body weight is transmitted across that one leg, right? Therefore, with time, what will happen? Chronically, when the patient keeps on limping, when the patient keeps on having the antalgic gait, what happens is his other good knee will also start undergoing osteoarthritic changes, right? So that is not a good thing. So he will keep walking like that, and eventually what happens? His right knee also gets osteoarthritic changes, right? So to minimize that, what do we tell? Hold the walking stick on the opposite side, that means on the right side, so that when he is giving more weight to that right leg, right, he can get some support and minimize the weight transmission across that right knee, thereby helping to protect that good knee that the patient has, right? Okay, so we tell him to walk like that, okay, right? Get some support from the walking stick for his good knee, right? I hope everyone understood that. Okay, right. Let me share the screen again. Right. Right. So we'll talk about this again in the treatment part, but then we don't need to discuss it again because now you all already know what is going on here with this antalgic gait and related to its treatment. So always remember, contralateral, hold it on the hold the walking stick on the contralateral side to the affected side, right? To the affected side. Right. Then guys, another thing you can observe, right? Another thing you can observe is anatomical deformity. Anatomical deformity. So maybe when you check the person's limbs on physical examination, you might come across a varus or a valgus deformity, right? Possible, not always, but possible, right? You all should know the anatomical deformity, guys, can both predispose to get osteoarthritis, basically act as a risk factor, or if the patient is an already diagnosed osteoarthritic patient, it can exacerbate the condition, right? Okay, right. Then guys, apart from this, we can also have some muscle wasting, right? Some muscle wasting, especially, look at this, quadriceps, guys. Quadriceps with regards to the knee, right? Quadriceps wasting. This is basically your thigh muscle, right? And then again, you will have reduced flexion, right? Problems with extension. They can have coarse crepitations, guys. Coarse crepitations again, right? We have discussed why these happen, right? Due to the irregularities in the articular surfaces, right? Even fissuring and fibrillation, right? The bones rubbing on bones, right? Eburnation, right? All of these changes, right? They can give rise to the crepitus, even the osteophytic formations, right? Apart from this, guys, they can have bony swellings, right? These bony swellings, guys, just remember these are swellings at the joint line. So for example, if the joint is something like this, at this line, there will be a swelling, right? At this line, right? If it is somewhere else, if the swelling is somewhere here, then you have to look for other underlying causes. There can be other conditions, guys, like some sort of bursitis, right? Or some cyst development, right? Baker's cyst, things like that, right? Okay. Answering bursitis, things like that, right? Okay. Then look at this, guys. The final thing I want you all to put, you all can put it as a note. What did we say? Even yesterday we mentioned this. Osteoarthritis, right? More commonly associated with pseudo gout. Why? We said, right? There can be some calcium pyrophosphate deposits, right? More commonly associated. Osteoarthritis of knee, huh? More commonly associated. The knee osteoarthritis. That's what I want to specify, right? Not just osteoarthritis. Osteoarthritis of the knee is more commonly associated with what? Pseudo gout. Okay, right. Come here, guys. Let's look at some x-rays here. Let's look at some imaging here of the knee. Look at this. This first one, guys. This first one is the normal. The first one is our normal one. Let's look at this second one, number 2. Look at this. What can we appreciate here? First of all, guys, there is joint space narrowing, right? Varied joint space. right? Somewhere here, look at this. These areas are very small joint space, right? Much larger in towards this end, right? So there is joint space narrowing, Then guys, look at this, osteophytes, right? Somewhere here also there is a little bit, right? Osteophytic formations, osteophyte formations. Apart from that, guys, here also, right? This is also most likely an osteophyte. Okay, right? Then look at this third diagram, guys. This third diagram, right? What can we see? We can see, right? Now look at this, guys. What is which side? If I say this is A, okay. If I say this is A side of the bone and this is B side of the joint, A side of the joint and B side of the joint, which one is lateral and which one is medial in this? How do we identify that? Look at this, guys. What is this bone here? This is the fibula. Fibula is located where? Laterally. Fibula is located laterally, right? So what can we see here, guys? First thing I want you all to appreciate, severe loss of joint space. This is bone on bone appearance, guys. Severe loss of joint space, right? In the lateral aspect, especially in the lateral aspect. Medial, there is relatively some joint space remaining, but still there is a reduction in joint space, right? Here, guys, apart from that, look at this structure, right? This is an osteophyte, right? Osteophyte, and look at this. This is significant sclerosis, guys. Maybe somewhere here also, right? Sclerosis, right? Subchondral sclerosis that we talked about, right? Subchondral sclerosis. Okay, right. Then we come to hip osteoarthritis. Hip osteoarthritis. Look at this, guys. Hip osteoarthritis. We say most commonly unilateral. Most commonly unilateral. Just know, guys, there is a bilateral variant. There is a bilateral variant, but this one is only in female. Only in females, huh? Right? Usually it's unilateral males and females. The bilateral variant is only in females. Only in females. Okay? Then the next thing, there can be, guys, superior lateral migration of the femoral head or superior lateral displacement of the femoral head. I put a picture here for you all, right? Look at this. This SL, this is superior lateral, right? When if the femoral head, the head of the femur moves in this direction, we call it superior lateral, right? A is axial, M is medial, right? So the head of the femur, guys, it can travel in any of these. It can be displaced in any of these directions. Superolateral is the most common one. Superolateral is the most common one, right? Okay, right. Apart from this, guys, there can be pain. There can be pain. Now, pain, guys, this is one of the earliest and most sensitive findings of hip osteoarthritis, right? There is pain, guys. This pain, just write it down, can restrict internal rotation of the hip, and right, there can also be accompanying anterior groin tenderness, right? Anterior groin region tenderness. Okay, apart from this, guys, right, especially in females, there can be restricted hip abduction due to the pain. So during intercourse, guys, during sexual activity, during intercourse, there can be exacerbated pain. Now, what I want you all to know is when you all are taking the history, be careful. This is not dyspareunia, right? Dyspareunia means what, guys? This is pain arising during intercourse again, but this is from the reproductive organs itself, right? From the vaginal canal, from the cervical region, from that region itself, right? That is dyspareunia. This is just pain due to the hip osteoarthritis, right? So when you're taking the history, right, be careful, right? It can either be a reproductive related issue or this can be just a hip osteoarthritis. Okay, right. The next thing is, guys, again, these patients also can have an antalgic gait, right? They can have quadriceps or gluteal muscle wasting. And now, what did we say is the most common type of migration of the femoral head or the dislocation? Superlateral. So what is happening? It's going upwards and slightly lateral. So the head of the femur, if this was the head of the femur, it is going to move a little bit up and slightly laterally, a little bit up and slightly laterally. Now, what's the important thing here? How will you see this clinically, guys? The patient, that affected leg, ipsilateral, since the femur is moving upwards, what is happening? The entire leg is moving a little bit up. So compared to the other leg, what will happen? That affected limb appears shorter, right? So this is what we call ipsilateral leg shortening. Ipsilateral leg shortening. Okay. Then we come to spine osteoarthritis, guys, right? Spine osteoarthritis mainly, right? This is not very common. Spine and shoulder osteoarthritis, guys, not very common. Shoulder is also pretty rare, right? Can happen in minors maybe, but it's quite rare, right? Spine osteoarthritis, guys, mainly cervical and lumbosacral vertebra are affected, okay? Again, there can be pain in the local area, right? If there is nerve root compression, if nerve root compression is there, right? What is the first thing we suggest? Get an MRI. Get an MRI, right? What are the signs that will suggest nerve root compression, guys? Radiation of pain, right? Usually along one leg, right? Usually along a unilateral one limb, right? Or there can be things like tingling sensation, pinprick sensations, okay? Tingling sensations, right? Along the affected dermatomes, okay? So if these signs of nerve root compressions are there, we tell the patient, we suggest the patient, go and get an MRI, okay? Right. Then, what we will see with imaging, guys, not very important, because for this spine osteoarthritis, one thing is not very common. And the other thing, there are much more high-yield topics related to the spine, like ankylosing spondylitis. That is a very high-yield topic, right? So those imaging we'll talk about in those chapters here. But that's why I didn't even put an X-ray, otherwise it might confuse you all, right? Here we can again see the bone spurs or the osteophyte formation and the narrowed vertebral discs, right? The intervertebral cartilages, right? They're getting narrowed, thinning, right? Basically the loss of joint space. Okay, is that clear? So those are the general diagnostic points I want you all to understand, right? The general diagnostic points I want you all to understand. Next, we can move on to the management, right? So we will take a 15-minute break, right? And come back. Okay, we'll take a 15-minute break and come back. All right. Right, guys. Now let's get into the management. Right. Let me share the screen. Right. Okay. Management. First of all, guys, we'll look at some general management things that we can do. Right. We can advise the patient. Right. We look at the general MX. Right. Generalized management. Right. The first thing I want you all to know, guys, right, no matter what we do, right, first thing, educate the patient about the disease, because these are chronic diseases, guys, right? So you have to educate the patient, right? What should we educate him about? We have to tell him, guys, one thing, right? You'll write this down. Huh? The structural changes, now depending on at what stage the patient comes to you, right? The structural changes already established, these are permanent, guys. We cannot change them, right? So especially these bony osteophytic changes, right? Some of these nodes, right? Heberder nodes, Bochart nodes, these are difficult to treat, right? Once they are established, they are permanent. But what can we do? Pain management, right? We can improve pain, right? Improve the management of pain and improve functionality of the joint, right? Okay, so you can tell those to the patient, right? Next, guys, if you just put a note somewhere, right? Put a note. If you look at the prognosis, guys, if you look at the prognostic value, right? Hand has one of the best prognosis, right? Hand osteoarthritis, right? After that, we get knee and hip is a little bit more difficult. And then the other ones, guys, like spine and shoulder, these are rarer, right? But their prognosis is also not very good, right? Hand has the best, right? Then we have to educate the patient on weight loss. We have to put them through a weight loss regime, right? So what does weight loss do, guys? It can help reduce the risk of developing osteoarthritis. At the same time, it can slow down the progression. Now, what should we know here, guys? Okay, one thing, right? According to research, what they have found out is a 5 kilogram, especially if the patient is obese, right? A 5 kilogram loss in weight, right, can reduce the chance of developing knee osteoarthritis by more than 50%, right? A 5 kg loss of weight, right? This is why weight loss is important. So for this weight loss, guys, one thing we can advise them on diet, right? The general things, reduced fast foods and all of these things, reduce oily food, right? These ones we can generally tell them. Apart from this, guys, we can tell them about exercise. Now, this is the important thing, right? Exercise we mentioned, right? Write these down. Huh? First one, do not overwork an already injured joint, right? This is the first point under exercise. Do not overwork an already injured joint. Okay. Do not overwork an already injured joint, right? The second one is, guys, do not completely stop all movements of the affected joint. That is the second one. First thing, don't overwork the joint. Second one, don't completely stop all movements of that joint, right? Don't completely stop movements of the affected joint, right? Why? What is the risk there if they stop? If they completely stop, what is the risk there? Yeah, muscle wasting. Muscle wasting can be exaggerated, right? Muscle atrophies, right? Therefore, what is happening? Joint protective mechanisms are going to reduce in functionality, right? Now, how do we tell them to exercise, guys? This one, there is no one proper regime, right? We cannot tell them do 20 minutes of walking. We cannot tell them one thing like that. What we have to do is, guys, we have to channel them to a physiotherapist, right? Channel them to a physiotherapist, right? The physiotherapist, guys, they usually know according to which joint, right, what kind of exercises to do, right? There are specifics. For example, if the knee joint is affected, right, they would increase the upper body exercises as opposed to the lower ones. And the lower body ones, they would do with the help of the physiotherapist, as in the physiotherapist will passively move the joints, right, to help the patient, okay, rather than the patient himself alone moving his affected joints, right? So channel them to a physiotherapist. Another one is, guys, hydrotherapy, right? Hydrotherapy, guys, especially for the lower limb osteoarthritis, like knee osteoarthritis, hip osteoarthritis, we can do this hydrotherapy. What is this hydrotherapy? Basically, patient is submerged in water, right? Usually, guys, if it is a lower limb, up to about the chest level and down, submerged in the water, right? Now, what does this submerging in the water do, guys? Now you all know, in the water, right, humans can usually float, right? There are some of us who can't, right? But that's a different story. But usually in water, humans, we tend to float, right? Why is that, guys? Why is that, right? There are some surface tension, right? There is surface tension that helps push us up, right? Okay. Now, because of this, the strain on the joint, right? The strain on the joints are reduced underwater. When you are in water, strain on the joints are reduced. But at the same time, in hydrotherapy, what do? We don't just tell the patient to stay submerged in water. There are some movements to do, guys, right? Just some generalized leg movements, depending on which part of the leg is involved, right? And with those movements, what happens? The muscle strength and the tendons and the ligaments, these are helped function, right? We help maintain the function. So we are helping maintain joint protective mechanisms like muscles and tendons while protecting the joint itself, right? While protecting, guys, did I get stuck? Guys, can you all hear me? Did I get stuck? Okay.
I can hear you now.
Okay. Where did I get stuck? Okay, so hydrotherapy, right? We submerge the patient in water. Can you all hear me now? All good? Thumbs up? Yeah, okay. So we tell the fellow to get in water, right? And then what we do is there are some exercises, right? Depending on what part of the limb is affected, right? So if the knee is affected, there are some leg raises to do, right? Gentle walking, right? Underneath the water, right? These kind of things, right? No exact things, no need for you all to know, right? Unless you all are specializing in physiotherapy or something like that. Okay, right. Then, guys, apart from this, for the general measures, another thing is, guys, right? Shock absorbing footwear. Shock absorbing footwear, right? Shock absorbing footwear, right? Or what is the other one? Walking stick. Walking stick. Now, walking stick, remember, right? Contralateral side to the affected limb, right? Hold it in the contralateral side's hand. Okay. Then for acute pains, guys, if there is a sudden onset severe pain, right? Let's say a chronic osteoarthritic patient, suddenly they wake up in the morning and throughout that day, they feel that that affected joint pains a little more than usual, right? So for that kind of acute pains, right? We can advise the patient to use ice packs, right? Ice packs or massage, right? Massage. Okay. Massage, right? Okay. Then, guys, we come to the medical management. So that was the general MX, right? General management. Now we come to the medical management, right? What sort of medicines can we prescribe, right? Write this down. First line. First line, we go with general. General, guys, to reduce the pain. What do we use? Paracetamol. Paracetamol usually combined with a topical NSAID, non-steroidal anti-inflammatory drug, right? Topical, guys, we give them a cream, right? Or there are sometimes gels also, right? Topical NSAIDs, right? This is our first line, right? Paracetamol, you all know, every 6 hours you can tell the patient if they want to take, right? 500 to 1000 milligrams, right? Dose is not very necessary here. This NSAIDs, guys, the topical NSAIDs commonly, what we have, one of the commonly used one is diclofenac creams, right? Diclofenac, right? One is diclofenac. Another one is, guys, methyl salicylates, right? These are creams, right? Okay. Diclofenac. How does this work? What is this? What is diclofenac? What is diclofenac? No idea. Okay, there are NSAID. No, how do NSAIDs work, guys? What is the basic pharmacology?
Inhibiting COX.
Yes, COX inhibitors, right? COX inhibitors. So same with this diclofenac is also working via the main pathway is COX inhibitors, right? Methyl salicylate, same. They inhibit cyclooxygenase pathway, right? So therefore, prostaglandin production is reduced and eventually inflammation is going to be reduced. That's why they are non-steroidal anti-inflammatory drugs. Methyl salicylates. Anyone knows any examples in the market? Some commonly used ones. Have you all heard Wintergino, Wintergreen, Wintergino? Huh? You all have heard, right? Then Tiger Balm, Flexol, right? These are some commonly used ones. Huh? Okay, I see some of you are nodding your heads, right? Just check in your local market which one is there, right? So these are some commonly used ones, right? Right. Okay. Then we come to the second one, guys. Another one, again, that can be used, right, within the first line. Again, this also can be used, right? Capsaicin, guys. Capsaicin creams, these are also creams. Topical. What is this capsaicin? Anyone knows what is capsaicin? Yeah.
It's from bell pepper. No.
Yeah.
Yeah.
Right. It's from capsicum, basically, right? Capsicum, right? This one, guys, capsaicin, this molecule, the capsaicin molecule is the one that it is a substance that is found in chili peppers, right? Specifically capsicum, that gives it its pungence, right? You all know, if you all have made any food with related to capsicum, if you all have even cut some capsicum, right, your hand starts burning, no, after a while. That is because of this capsaicin, right? So what they have found out was they developed a cream using this capsaicin. right? Now, very common, huh? Right? Like even I have actually brought it. I forgot to bring it. Even for my dog is also suffering from osteoarthritis. Okay, not the fellow who caught the lizard, huh? The other one. The fellow who caught the lizard is very young and very active. The other fellow is a little bit old, about 10. Yeah, she's 10 years old. So she has a bit of arthritis. Huh? For her also, the vet has prescribed a capsaicin cream, right? I will send a photo in the group later, right? What this does, how this works is, guys, look at this. We'll take a small look, right? Just to get an idea, right? Interesting things, right? Look at this. If I draw, this is our genera, let's say joint, right? Synovial joint, right? Okay, the synovial joint. Now, what did we say, guys? The synovium has a good vascular and nervous supply, right? Nerves are there, and there are nerve fibers, guys, that go to the spinal cord, right? We'll look at what these are and go directly to the brain, right? Directly to the brain. We'll look at what these are. Don't worry, just draw a rough diagram, right? Okay. Some of these fibers, guys, we said some of them are mechanoreceptors and some of them are nociceptors. They are receptors here. We call them nociceptors. Nociceptors, right? Nociceptors. So these are pain fibers. They give rise to pain fibers, right? Pain fibers. If you all read more, guys, in the pathophysiologists, you can see A fibers, C fibers, right? For the pain, right? There are various types, right? We don't need to talk about all of that. What I want you all to know here is, guys, if we take a closer look at one of these nerve fibers, at one of these nociceptor endings, right? And let us take a closer look here, right? We'll zoom into one of these nociceptor endings. It's going to look something like this, right? Something like this, right? There are some nerve endings, and then that will go all the way. We will see into, first it will go into the spinal cord, right? Whichever level that is, right? Right, something like that, right? It will come all the way here, right? And it will then synapse with a second order neuron. Don't worry, we'll look at this, huh? This second order neuron for pain, guys, usually goes through what tract? Don't worry, the neurology. If you all know, just tell me somewhere here. Yes, the spinothalamic tract, right? It goes to the spinothalamic tract, and then from there it ascends. It ascends, right? It ascends all the way, guys. It goes through the pons, the midbrain, all these structures, eventually goes to the cerebrum, right? We are not going to draw all the structures. There it will go and combine with some other third order neurons and finally go to that part, right? Not necessary. Look at this. Here is what we need to know. Now, this capsaicin cream, it contains this capsaicin molecules, right? Capsaicin molecules. Capsaicin molecules. Okay. Capsaicin, guys, what does it do? It gives you a burning pain, right? If capsaicin comes into contact with your skin, it gives a burning pain sensation, right? Burning pain sensation. Now, how does it do this? In this nociceptor nerve endings, guys, there is a receptor for capsaicin. There are receptors for capsaicin. Receptors for capsaicin. Okay. This receptor is what? Does anyone know? Right. Students who came for my endocrinology module, there was a special type of receptors. There was a special type of molecule, a transmembranous molecule present in our osmoreceptors. Do you all remember what that is? I said it goes through the membrane 7 times, like a snake.
Transmembrane.
Yeah, correct. Close, right? You all remember. So it's something like this. It goes through the membrane 7 times, and it has a calcium channel attached to it as well, right? A calcium channel attached to it as well. TRPV1, remember? Transient receptor potential vanilloid, right? Okay, not necessary to know this receptor, but what I want you all to know is that this is the receptor that senses capsaicin as well, right? Okay, same receptor, Okay, same receptor. Now look at this. Capsaicin molecules are here, right? From the capsicum or from the cream, both. They come and they can join to this, right? Capsaicin. Now, when this 7-fast receptor is activated, right? What happens to this calcium ion channel that is present? It opens. Remember, same mechanism. Calcium ion channel opens. So what happens, guys? There is a rapid influx of calcium Ca2 plus into this nerve terminals, right? So what is happening? Nerve gets depolarized, starts firing an action potential, right? It starts firing an action potential. Now, what are these fibers? These are pain fibers, we said. So the pain fibers, when they start firing action potential, guys, right? They come to the spinal cord here and they release a special neurotransmitter. These pain fibers, they release a special neurotransmitter called substance P. Substance P. Okay, substance P. Right? Okay, and that is what will help transmit the nerve impulse through the second order neuron and then upwards. Okay, now this is what happens in normal capsicum. Normal capsicum or chili peppers, if they come into contact with your skin, this is what happens, right? Now we adopted this to the capsaicin cream. What does this do, right? The capsaicin cream, guys, when you apply, right? Now let's say this joint, this patient already has some pain due to his osteoarthritis, right? Due to his osteoarthritis, he has some pain. When you apply the capsaicin, this patient's TRPV1 receptors will get activated. They will start firing impulses of burning pain through the pain fibers. And this substance P will be produced a lot, right? Because locally you are applying the cream. So a lot of substance P produced, right? Initially, what does the patient feel when he applies the cream? He feels it's burning, right? He feels it's burning, right? This is why I'm worried about my dog also. Probably it's burning for her also, right? Can't help, right? But how does this help? Eventually, this substance P will be weared off, guys. This substance P, this neuron has a limit of substance P that it can produce, right? So what does capsaicin do? It exhausts the neuron of substance P. So initially it will burn, but within about 10-15 minutes, sometimes half an hour, what is happening? The neuron still getting stimulated by capsaicin, right? But no substance P. No substance P. The neuron has finished producing and releasing all its substance P. Without substance P, can pain be transmitted upwards? No, right? Without substance P, no pain can be transmitted. So what is happening, right? The arthritic joint, same phenomenon, right? If it's the elbow, let's say the patient applied this capsaicin cream for a few minutes, it will burn and then pain disappears, right? Because from that entire area, those neurons now don't have substance P. Okay, right? So that is how capsaicin works. Okay, substance P. Yes.
If there is any trauma after applying the cream, there will the pain not be felt like at the
First
same.
thing, okay. First thing, never apply capsaicin cream onto damaged skin. If mucosa is intact, never apply capsaicin cream. Is that what you're asking?
No. Like
Okay.
after, like if you apply the cream and there, like by chance there is any trauma to the same site, will the pain be felt or
at the exact same local area? No.
Yeah.
At the exact same, but now let's say this is the patient's elbow, right? Elbow area. Let's say this is the elbow. Let's say you apply the cream here. Even if it is an inch away, guys, even somewhere here, pain still can be felt. Okay, even a very minor distance, right? Pain is still there because pain fibers are all over your skin. Okay, right? Nociceptors are there. Okay.
So it uses up substance P and hence
yes, that is the mechanism of action. It exhausts the neuron of substance P. and the neuron doesn't have any more substance P to produce and transmit the pain to the brain. Okay, right? That is this capsaicin cream, right? This one actually, guys, especially for osteoarthritis. Now, osteoarthritis, you all know this is a chronic condition. This is a chronic condition. So this capsaicin cream is preferred to topical NSAIDs because topical NSAIDs, if we use for a long period of time, you all know there can be side effects related to NSAIDs. So we prefer this capsaicin cream over that, especially for long-term treatment procedures. Okay. The one that we have in Sri Lanka, guys, is called Transpain. Transpain. This is the brand name. You all can just check. Transpain, right? Right. Usually 0.5% capsaicin, sometimes 1%, sometimes 2%. Right. There are different preparations. Okay. Right. Then, guys, if the patient still remains symptomatic, this is the second one. If still symptomatic, right? Or if these initial first line ones don't relieve the patient of these symptoms, right? You can add oral NSAIDs, oral non-steroidal anti-inflammatory drugs, right? Oral NSAIDs, right? Here, guys, the common ones that we usually use, right? One is ibuprofen, right? Another one is oral diclofenac, diclofenac oral. And the third one is, guys, the newer ones, celecoxib, right? Coxib. Celecoxib is what? What is celecoxib? Those who came for my GI classes?
COX-2
inhibitor.
Yeah, selective COX-2 inhibitor. This guy is a selective COX-2, cyclooxygenase 2 inhibitor, right? Selective cyclooxygenase 2 inhibitor, right? Now, what do I want you all to understand here? First thing, guys, with oral NSAID, what is the definite risk that you all already know?
Peptic ulcer.
Yes, one of the most important ones is peptic ulcer disease. Peptic ulcer disease with oral NSAIDs, right? So, if the patient is at a risk of peptic ulcer disease, what do we prefer? Selective COX-2 inhibitors or something like ibuprofen or diclofenac? Which one do we prefer? Yes, we prefer good. We prefer celecoxib if the patient is at a risk of peptic ulcer disease, right? On top of that, guys, what else can you do? Or what other drugs can you add for this patient who is at a risk of peptic ulcer disease?
PPI.
Excellent. You can add a proton pump inhibitor, something like omeprazole or esomeprazole, right? Okay. You can add a proton pump inhibitor, right? Okay. Right. So that is another one. What about if the patient is having some cardiovascular risk, guys? Cardiovascular risk. Out of these three, right? Which one should we maybe try to avoid?
Celecoxib.
Yes. Out of these three, try to avoid celecoxib. And also, guys, diclofenac also has a high cardiovascular risk, right? High cardiovascular risk. But celecoxib is the most dangerous one for cardiovascular events. Why is this? You'll have to think about the COX pathway now, cyclooxygenase pathway.
Platelet addition.
Right. Platelet aggregation is done mainly by COX-1 or COX-2. You all remember. Look at this. Let's recall, right? Let's recall. There is this. Okay, look at this, guys. There is membrane phospholipid metabolism. Phospholipid metabolism occurring. This is done, guys, with the help of an enzyme, and this produces arachidonic acid. Arachidonic acid. What is this enzyme, guys? What is this enzyme here? Anyone?
Phospholipase.
Yes, phospholipase A2. Phospholipase A2. Right? This arachidonic acid, guys, it can go into two pathways: the cyclooxygenase COX pathway or the LOX, right? LOX, lipooxygenase. COX or LOX, right? Cyclooxygenase or lipooxygenase. Look at this. We'll look at this COX1. COX, guys, can go to COX1 or COX2 pathways. COX2 pathways, right? Now, COX1, cyclooxygenase 1, guys, it mainly produces thromboxane A2, right? And prostaglandin I2, right? Cyclooxygenase 2, COX2 mainly produces prostaglandin D2 and prostaglandin E2, and there is a little bit of function in producing I2 as well, right? Okay, this is the major cyclooxygenase pathway, right? Now look at this. Thromboxane A2, right? What does this do?
Platelet aggregation.
Platelet aggregation. Platelet aggregation, right? And with regards to the vessel, can it do anything?
Vasoconstriction.
Vasoconstriction. Prostaglandin I2, what does it do? This one, guys, acts on many places, right? Our gastrointestinal tract, our urinary system, right? The kidneys, the bladder, it can act on many areas, and it does this thing what we call housekeeper function, if you all remember, right? Housekeeper functions. So for example, in the stomach, what are the housekeeper functions done by prostaglandin I2? Does anyone remember? These are basically gastroprotective mechanisms. What does it do?
Mucus production.
Yes, increase mucus production, increase bicarbonate. What about the acid? Reduced acid production. Yes, reduced acid. Then what about the mucosal blood flow? Do you all remember? Increased mucosal blood flow, right? Okay, I hope you all remember. Go back and look, right? Prostaglandin. So how do these cause increased mucosal blood flow, guys? Vasodilation. All these prostaglandins have a vasodilation function. Vasodilation function, right? Vasodilation function. Okay. And these prostaglandin D2 and E2, guys, they have a special role to play in inflammation, right? Inflammation. Either way, right? Look at this. Now, look at this. We have, from the cyclooxygenase 1 pathway, we have vasoconstriction. From the cyclooxygenase 2 pathways, we have mainly vasodilation. Now, regarding cardiovascular risk. Now, can you all understand? If vasodilation is prevented, what is happening? Vasoconstriction everywhere. Vasoconstriction. So the chances of ischemic attacks, right? Chances of strokes, even exacerbation of heart failure, all of these can happen. So when there is a cardiovascular risk, guys, you should try to stay away from COX-2 inhibitors, selective COX-2 inhibitors. Okay, right? Okay, right. So that's about that. Then we go to the next one, guys. Number 3. Okay. We'll put number 3. Corticosteroid injections to the joint space. To the joint space. Now, in this cycle, where does corticosteroid act? In this membrane phospholipid metabolism that we drew, where do corticosteroids act? What does it do?
Phospholipase A2 inhibition.
Excellent. It inhibits phospholipase A2. This is where corticosteroids act. Right? Corticosteroids act. Right? So inflammation. Now, you all know, guys, from the lipooxygenase pathway, what do we have? we have many leukotrienes coming, right? LTB4, LTC4, D4, E4. I hope you all remember these are essential for inflammation and chemotaxis, right? Leukotriene B4, C4, D4, right? Anyway, so both of these pathways are inhibited by corticosteroids. So it helps reduce inflammation to a great extent, right? Specifically, guys, this is most commonly prescribed, right, for knee osteoarthritis and hand, in the hand, guys, especially to the first carpometacarpal joint. Remember, right, the first carpometacarpal joint, we talked about the squaring of the wrist and all of those changes, the severe sclerosis, right? These two areas, especially, we can recommend corticosteroid injections, right? What I want you all to know, this one has a very short duration of action, guys. Short duration of action. What do I mean by short? Usually, guys, after one injection, right, the pain relief will last for about 1 to 1.5 months, maximum maybe 2, right? Maximum maybe 2, right? After that, depending on the severity, they might have to again get an injection or something, right? They will assess, the clinicians, the physicians will assess the degree of damage, and they might have to again get another shot. Now, what is the risk with corticosteroids? I mentioned this yesterday as well. What is the risk?
AVN.
Sorry? I did not hear. What is the risk?
Avascular necrosis.
Yes, avascular necrosis. Avascular necrosis. There is a risk of avascular necrosis. Therefore, guys, now tell me this, if the osteoarthritis is very severe, right? Then what does that tell you? Most likely, we will have to give this patient repeated doses, right? Maybe every 3 months, you might have to give them corticosteroids, right? Therefore, is that a good idea? Is that a good idea? Multiple repeated doses, there is a high risk of avascular necrosis. Therefore, guys, if the osteoarthritis is too severe, right, we tend to not go with this treatment, right? This is different for rheumatoid arthritis. For rheumatoid arthritis, you will see, guys, we corticosteroid injections, and there they use corticosteroid oral also. Here, no indication for oral, right? Corticosteroids only injection. That also, right, moderate to severe, not very severe osteoarthritis. Okay, moderate to severe, yes, you can. Okay, right. Then, guys, the next one, number 5. This one you all already know. Tell me, hyaluronic acid injections. Tell me, how does this work? What does this do? Why are we giving this? Guys?
To increase the shock.
Yeah, hyaluronic acid is the one increase in the viscosity, and helping reduce friction, right? This is recommended, guys. Now, currently this is approved by the FDA only for knee osteoarthritis, only for knee. Okay, currently approved only for knee osteoarthritis. Okay, this one, guys, the thing is, right, it is good, but one thing, it lasts longer. It can last about, guys, they say 6 to 9 months. The pain relief can last 6 to 9 months due to the reduction in friction. But the thing is, the onset of action also takes time. Onset of action can take about 1 month, right? Onset of action can take about 1 month. After giving the injection, for about 1 month, the patient will still be in pain. Okay, right? Right. Now, final, this is our medical management, guys. The final one is surgery. We are not going to discuss in depth, right? This is not our module, right? But we'll talk, just mention a few. Surgical management, right? Surgical management. What can we do? First thing, guys, I want you all to know, surgical management for osteoarthritis is a very, very, very last option, right? Last option. We almost never do this. Right? Write this down. Consider surgery if, right? A few things. First thing, severe pain, severe, you can say persistent pain, right? You can put in brackets plus or minus nocturnal pain, plus or minus nocturnal pain, right? Okay. Yeah, which is refractory to medical management, right? So pain that doesn't go away with medical therapies. Okay. Then guys, second one, right? Severe reduction in joint function, severe reduction of joint function, right? Severe reduction of joint function. Basically guys, here what we are talking is about reduced quality of life, reduced quality. They cannot even do basic activities, right? Walking, right? Washing their hands, even eating, sometimes they can't even eat with their hands, right? If their quality of life is severely affected, then yes, we can consider surgery. Okay, right. The main procedures, guys, I want you all to just know, right? The main procedures that we commonly do, right? One is total joint replacement, right? So right now we have many types, guys. Knee replacements, hip replacements, right? We have all of these, right? Total joint replacement. They remove a lot of the cartilage, destroyed cartilage. They remove destroyed bone parts as well, right? And they replace the entire joint. This one, guys, I want you all to know currently, right? 85 to 90% success rates, right? Their joints, guys, work perfectly well, right? Well into the second decade, greater than 20 years, right? After the surgery, even greater than 20 years after the surgery currently, right? They work well. Okay, right? 85 to 90%. There are some cases, guys, even after joint replacement, there is problem, right? There are some rare cases, right? Because if the chronic risk factors are not reduced, again, the surrounding bone can get a little affected, right? Especially if they are obese, right? Things like that, right? Then, guys, the second one, which is now not usually commonly done, osteotomy, especially if the bone is heavily disfigured, right? Or abnormal, right? We can cut off those pieces of bone, guys, right? Okay. That's a surgery not commonly done, right? Usually to prolong the life of malaligned joints, right? You can do this osteotomy, right? Right. What are the complications of surgery? The complications, guys, not very much, right? One thing, since you are dealing with the bone and the cartilage and those associated structures, there is a chance of fat getting into the blood, right? Fat getting into the blood. There is a chance of venous thromboembolisms, right? Venous thromboembolisms. And the second one is, guys, sepsis. Okay. These ones, guys, these are very rare, right? Less than, they say, 1 to 2% of the surgeries will have these complications. But what do I want you all to understand? Very rare complications, but very real complications, very serious complications, right? Very rarely do they occur, but if they do occur, very serious and very life-threatening. Because of this, surgery is the last decision, final option, you can say. That's why we use surgery as the final option, because the complications are minimal but very serious complications. Okay, so that opting for surgery is a very critical decision, right? That has to be made as a last option. Okay, right? Did everyone understand the content? We are done with osteoarthritis. Okay, let me see some faces. Right, you all can now go and sleep. Okay, look here, guys. Did everyone understand? Give me a thumbs up. Let me see your faces. All good? Right, excellent. Right, if you all have any questions, right? Now osteoarthritis is over. The next chapter, I do not have the timetable. It's on my phone, right? I think it's gout. I'm not sure. Just check. Is it? Yes. Okay. Right. So Shan will be teaching that to you all, right? If you all have any question now, in the upcoming days, guys, I will put some questions related. Now, even during the session, I talked to you all about some true or false stems. I will put some questions in our Telegram group. Okay, if anyone is still not in the Telegram group, drop me a WhatsApp message personally. I will send the link to you all. Right, try those questions in Telegram, guys. When you try the question that we put, right, no one else can see your answers. Huh? Even the person who puts the message can't see the answers. So don't worry, right? Just try, and if you all don't know, guess. If you all have a problem with the questions, take a screenshot, send it to me. Okay, asking why, right, or what is going on here, right? So that's about it, guys. Hope you all understood osteoarthritis, right? If there is any question, drop me a message. Okay, right? I will see you all in the next session. Okay. Okay. Good night. Right. Have some good rest. Okay?
Thank you.
Right. No problem. You're welcome.